Hi, welcome. It is Tuesday, April 28th, House Healthcare. And we have with us today, we are taking up S-190, which is the one bill left on our Senate bill on our wall that we haven't done a walkthrough of yet. So we've got Jen in here this afternoon to do that. And then a couple witnesses to sort of ground us in the bill before we start diving into it.
Good afternoon, Jen Carvey from the Office of Legislative Counsel. I will put the bill up on the screen. This is S-190, an act relating to the Green Mountain Care Board, reference-based pricing, and stating the creation of a public employee health benefit authority. It starts out, we've got some reader assistance headings, the different topics addressed. So we start out with several sections on reference-based pricing. The first section amends the statute that in part directs the board to begin implementing reference-based pricing and adds some new language starting on the top of page 2, saying that for provider contracts that are entered into, amended, or renewed on or after October 1st of this year, each hospital and health insurer shall begin expressing as a percentage of Medicare or another benchmark if the board uses a different benchmark, but let's say using as a percentage of Medicare, the rates for items and services identified pursuant to a collaborative process between the board and representatives of Vermont hospitals. So for new provider contracts starting on October 1st of this year, the hospitals and insurers are going to begin using references to Medicare, percentages of Medicare to express the rates for certain items and services. Also, when making public the charges for items and services as required by federal law, this is the federal hospital price transparency requirement, each hospital shall include in its machine readable files pricing information shown as a percentage of Medicare rates, as well as in dollars and cents, disaggregated by payer and by plan. And then it specifies that for both of those provisions, for the provider contracts using Medicare rates to show the percentage of Medicare rate and making public the charges, a hospital may express rates as a percentage of Medicare based on the actual reimbursement amounts the hospital receives from Medicare for items provided and services delivered to Medicare beneficiaries, until such time as the Green Mountain Care adopts a rule establishing the methodology for determining Medicare rates for use as a benchmark in establishing reference-based prices. So for the near term, hospitals can use their actual Medicare rates that they receive and show the percentage based on their own experience of Medicare rates, not on a statewide standard Medicare rate, until the Green Mountain Care Board adopts a rule establishing how to calculate Medicare rates on a more consistent basis.
So would this require back in CI, it would basically, that they shall, doesn't say like, hey, we think this is a good idea. It says they shall, every service should be like Medicare
items and services in lines 4 and 5 identified pursuant to a collaborative process between the board and representatives of Vermont hospitals. So they'll sort of figure out how to implement this. So they're going to begin expressing this way for these services.
So the problem, I'm sorry, the way things are now with certain types of services where it's just like, we'll give you a % off of charge, that's still going to happen through this collaborative process.
Yeah, so and the payers and the hospitals can tell you more what this looks like from their standpoint. But as I understand it, they will still figure out the rates, the dollar amounts, but they will tie them to a percentage of Medicare, so that there is some, so that people start getting used to looking at rates as a percentage of Medicare or another benchmark. All right, and then in further down on page 2, it requires each hospital to apply for, obtain, and use a national provider identifier on all claims filed after October 1st, 2027 for reimbursement or payment of items provided and services delivered at an off-campus department of the hospital that is distinct from the national provider identifier used for services delivered at the main hospital campus or at any other off-campus hospital department. So this is, there's some work happening at the federal level as well, and I believe starting January 1st of 2028 is when all the hospitals have to be doing this anyway. But this is starting to look at having different national provider identifier numbers on claims for services delivered on hospital property and in outpatient departments and each outpatient department, so that we can get a better sense of where exactly care is being delivered. And it uses campus has the same definition as in federal regulation, and off-campus means a facility that's located more than 250 yards from the main hospital campus, which is, we have some similar language in an existing statute around Medicaid. So I just used the same.
Just a clarifying question. You're saying that each off-site place has their own unique NPI number?
Right. It will.
Yeah, someday.
Okay, section 2. To orient you now, we are in the subchapter on qualified health plans. We're in the exchange in Title 33. So 33 DSA 1815. It's the next section in adding to that subchapter on qualified health plans, and this has limitations on hospital reimbursements. It starts out with a definition of Medicare adjusted base rate, which is a term that gets used in here. And that means the standardized Medicare payment amount for a hospital inpatient, outpatient, or professional service as determined under the Medicare program, calculated prior to the application of any hospital-specific, patient-specific, or policy-based payment adjustments, and reflecting only the core payment methodology used by the Centers for Medicare and Medicaid Services to establish baseline payment levels, which include adjustments for geographic factors such as wages. It's a long way of saying this is going to be kind of that idea of a standardized across the board Medicare rate that can be used to calculate percentages up or down from. So this is different from, this language was originally both sections in the bill that was introduced in the Senate through the committee process. They made a change for this earlier part we looked at where the hospital can use their actual experience of the Medicare reimbursement rates. This is looking at having a standardized Medicare payment amount before there's some sort of hospital specific, patient specific, and other adjustments. And then it's specified.
Just for QHP.
So this is just a definition at the moment. We haven't done anything with it.
This is only in Vermont. This is, the definition is just Vermont, or is it?
Yes, I don't
It's not
believe,
across the
I don't
country.
believe this Medicare adjusted base rate definition is used, or at least used in this way. But the Vermont Care Board could tell you more about how they developed it. For items provided and services delivered at a critical access hospital, the Medicare adjusted base rate will be determined under the applicable Medicare prospective payment system using the Medicare payment methodology that would apply if the hospital were not designated as a critical access hospital. So just trying to sort of, again, treat everybody, have everybody using the same numbers. So that's where the Medicare adjusted base rate. So there's no word looking for a kind of standard Medicare rate, because here's where it gets applied. It says a registered carrier shall not reimburse or agree to reimburse a hospital more than 250% of the Medicare adjusted base rate, that definition we looked at, for any item provided or service delivered in Vermont to an enrollee in a qualified health benefit plan. So this is setting a 250% of that Medicare adjusted base rate cap on hospital items and services for Vermonters in qualified health benefit plans. And then it gives some information about what to do if there's not fee for service. So if the carrier is reimbursing a hospital for an item or service on a capitated or other non-fee for service basis, then the carrier must ensure that its reimbursement method is adjusted to account for this 250% of Medicare adjusted base rate limit in subdivision law. It says this reimbursement limit The 250% cap would remain in effect unless and until the board establishes, the pre-Medicare board establishes a different reference-based price under its reference-based pricing authority. It says a hospital or hospital provider that is reimbursed in accordance with that cap shall not charge or collect from the patient any additional amounts other than the cost-sharing amounts authorized by the terms of the health benefit plan. So no balance billing, as we typically use the shorthand for that, no balance billing the patient, no asking the patient to pay over the 250%. The only thing they can charge them is their cost-sharing amounts that are authorized under the plan. And then in its review of premium rates and its review of the QHP rates, the Green Mountain Care Board must ensure that that limitation, the 250% cap, is appropriately reflected in the premium rates for qualified health benefit plans. So setting a cap on the amount that gets paid on behalf of QHP beneficiaries to the hospitals, and wanting to see that cap, that limitation carried through to reduce premiums or reduce the increase in premiums for the qualified health benefit plans. With me-ish so far? All right, great. Section 3. Now we have moved again. Now we are in the hospital budget review subchapter that is now getting retitled a little bit to be the hospital budgets and budget review. We start out first with the definition, and this is that same definition of Medicare adjusted base rate that you saw applied to in the QHP statute that we just looked at. So it's adding a definition of Medicare adjusted base rate, so we can use it in this subchapter as well. And then it adds a new section 9459, targeted commercial reimbursement rate reductions. This directs a hospital to implement any commercial reimbursement rate reduction that the Green Mountain Care Board orders as part of a hospital budget order through the limitations on its commercial reimbursement rates for qualified health benefit plans in accordance with the section that we looked at before. So it says if a hospital is directed to reduce its commercial reimbursement rates, the first place they go is the 250% cap for the qualified health plans. To the extent that a hospital is required by the board's budget order to reduce its commercial reimbursement rates more, reduce them by amounts greater than the reductions that they achieve by targeting those 250% cap, then the hospital is directed to reduce its commercial reimbursement rates that exceed 500% of the Medicare adjusted base rate. So go for the highest rates first, or if the hospital doesn't have any commercial reimbursement rates that are over 500% of the Medicare adjusted base rate, then by reducing its commercial reimbursement rates that are the highest in relation to the Medicare adjusted base rate. So if they're directed to reduce commercial reimbursement rates, the first place that gets implemented is they're already being directed to do the 250% cap for the qualified health plans. If they still need to reduce their rates more in order to meet the budget ordered by the board, they look first at anything that they are charging more than 500 or imposing through contract, but 500% of the Medicare adjusted base rate. If they don't have anything that high, then go to whatever is the highest and start reducing there.
Is there anything in here that, particularly around the 250, that if your charge is currently, some of them are under 250, that you can't raise them?
No.
Okay.
It's here, so we should look here in subsection C says except as provided. So except as provided in the caps and the places you're supposed to go first. In fact, a hospital may increase its commercial reimbursement rates for one or more of its service lines, such as primary care, as long as in doing so it remains compliant with the total budget ordered for the hospital. So yes, for QHPs, they have to stay under the 250%, but it doesn't mean they can't increase rates above 250% or increase something that is currently at 175% to 200%, as long as it stays under the 250. So they can move some things around as long as they stay within their budget folder. And you'll hear from stakeholders on it.
But that language right there doesn't actually tell them what service line. It could be any service line. such as, I mean, such as isn't really, is that just a definition essentially? Hey, we're talking about a service line?
No, it's just, I mean, it's giving an example.
Oh, okay.
All right, then we have section 4 on implement, so now we're not in statute at all, just session loss provision. Implementation of reference-based pricing for certain public health employee health plans and a report. This directs the Green Mountain Care Board in consultation with DFR and Department of Human Resources and VHI, the Vermont Education Health Initiative, directs them to analyze commercial health insurance claims for inpatient and outpatient hospital items provided and services delivered to active and retired members and their dependents enrolled in the state employees health benefit plan and in the health plans offered to teachers and other school employees through VHI, to determine the opportunities available through the use of reference-based pricing and the projected impact on Vermont's hospitals. So there's interest in expanding the use of reference-based pricing, particularly among some of the public employee plans. So this is having that looked at specifically, and also what the impact would be on Vermont's hospitals. And it requires VHI, Department of Human Resources, and the administrator of the state employees health plan to provide the board with access to the claims data needed to perform that analysis. Then by January 15th of 2027, the board would provide to this committee, Ways and Means, and the Senate counterparts, the board's findings and any recommendations with respect to scope, timing, financial impacts, and other considerations in implementing reference-based pricing for items and services in the state employees health plan and health plans offered by DFR.
Right.
So we're implementing reference-based pricing for hospitals. And then we're studying how to implement it for other components of healthcare for public workers.
So right now, you have sort of generally told the board to start implementing reference-based pricing with respect to hospitals. And you have, if you enacted the bill as it came over from the Senate, you are going specifically at implementing a reference-based price for qualified health plans. This is looking at implementing reference-based pricing for other specific health plans.
So so this bill currently only implements reference-based pricing for hospitals hospitals charging payers of qualified health plans.
No, it is only establishing the reference-based price and directing implementation of reference-based pricing. You've already set up what you did last year. You gave the board direction to begin implementing reference-based pricing. But you didn't tell them a percentage because you wanted them to figure that out. You gave them methodology and a framework, and they're working on implementing it. This is proactively legislating reference-based pricing for the qualified health plans with a specific reference identified of
But
$250.
the hospitals are, they're only charging a reference-based price to the patients who have qualified health plans.
To those payers. Based on this, they're only required. The board may require them to be doing reference-based pricing for hospital services with other payers, because that's what you told them to begin implementing. But the board isn't, I mean, and the board will testify, so you can ask them where they are with implementing reference-based pricing, but they will be going through rulemaking. There's still some process before they will be able to set reference-based prices. And so this is having the legislature set a reference-based price with respect to a portion of the population.
Yeah, and so with this bill, we're only setting a reference-based price for hospitals for a specific fraction of their income or their clients or their revenue.
For their patients, right?
Yeah, and then studying the expansion of reference-based pricing only for people who have benefits due to their jobs as a public worker.
Okay, you said it. So I'm going back to the beginning of the bill because this is what you enacted last year. You direct the board to begin implementing reference-based pricing as soon as practicable, but not later than hospital fiscal year 2027, which starts October 1st, by establishing the maximum amounts that Vermont hospitals shall accept as payment in full for items provided and services delivered. and talks about what happens after initial implementation. You talked about also having them, I don't think it's in here, but you have language in the existing statute that also directs them to look at the potential for implementing reference-based pricing for other providers, other beyond hospitals, but for now, you've only set it up for hospital, but it's still in the process of implementation at the Green Mountain Care Board, including rulemaking. So there is no reference-based price set with respect to any population, leaving aside Medicaid, which may be doing some of its own. So this is going in and starting reference-based pricing with a segment of the population. A segment of the population, I think this committee and others have talked about concerns regarding the premium increases. So an effort to reduce the premiums for those plans. There has been significant interest among other payers in the system, including the teacher plans, VHI and the state employee plans and property taxpayers, I think you've heard, in reducing their expenditures as well. There was concern, at least in the Senate committee, about rolling out reference-based pricing, at least with a set percent too early, too quickly, without knowing whether 250% was the right amount or what the impact would be on hospitals. So the Senate bill has reference-based pricing at 250% cap for qualified health benefit plans. It is taking a targeted look, a focused look at what it would look like to implement reference-based pricing in certain public employee health plans and getting you the information on that. Trying to balance the kind of competing concerns of people who are paying for the care and the hospitals that are getting paid for the care. And this committee can make any changes you want.
All set, Brian?
Next, we have hospital outsourcing. And I think we will hear more about we'll talk more about hospital outsourcing as well. But the language in this bill says that for fiscal year 2027 hospital budgets, the board will direct hospitals to provide whatever information the board may require regarding the clinical services that the hospital outsources to external entities. And then in January, by January 15th of 2027, the board, after consulting with hospitals and their contracted independent providers and assessing the impact of outsourcing on access to and quality and availability of care, will provide findings and recommendations on hospital outsourcing to this committee and others. In addition, the board, in collaboration with the Agency of Human Services, will report on the extent to which hospital outsourcing affects provider tax revenue and recommend any necessary changes to the provider tax provisions to appropriately reflect expenditures for patient care at Vermont hospitals.
Leslie?
So just a clarification on outsourcing, is that for clinical stuff, like if you contract with an ER group, or is it if you're doing your linen, like what?
Just clinicals. It's talking about clinical
clinicals.
services. Yep,
Okay.
talking about clinical services.
Thank you. Independent contracted providers, so that's what this.
And we'll take testimony on outsourcing.
Yeah,
That's
good.
that's not a topic that we
Ever touch.
really go into.
Okay, then we have a section on reader assistance heading sort of tells you where it's going, excluding reference-based pricing from the scope of healthcare professional bargaining. There's an existing statute on healthcare provider bargaining groups that allows the Green Mountain Care Board to approve one or more healthcare provider bargaining groups and what they can negotiate about with whom, et cetera. This has language in it saying, notwithstanding any provision, the section to the contrary, the Green Mountain Care Board shall not be required to negotiate with the provider bargaining groups or engage in a non-binding arbitration process in connection with the board's establishment of reference-based prices in accordance with the various provisions in the Green Mountain Care Board statutes. Hear more from the board and the provider about the healthcare provider bargaining groups. Section 7 deals with appeals of Green Mountain Care Board orders. This amends 18 VSA 9381, which is the Green Mountain Care Board appeals statute. current law requires the board to adopt procedures for administrative appeals of its actions, orders, and other determinations. And then after the administrative appeals, there would be the potential for judicial review. And so that's in here in a couple of places. As I understand it, the board has never adopted these procedures, and all appeals go to the Vermont Supreme Court, and have been. So the board had requested removing the language about administrative appeals. Sections 8 and 9 around data infrastructure, specifically a health system performance tool. This amends an existing statute that requires the Green Mountain Care Board to develop and maintain a public interactive internet-based price transparency dashboard that allows consumers to compare prices. And it adds new language requiring the board to develop and maintain a public interactive tool that displays information on health system performance, including information regarding quality, access, and affordability, and that the board update the information in this health system performance tool on a regular basis to the extent operationally feasible. Section 9 says the board only has to develop that tool if it receives sufficient funding from the federal government or another source for this purpose. I believe it was part of the rural health transformation application, and so you may be able to hear from others about whether that funding was received. Section 10 creates the Public Employee Health Benefit Authority Study Committee. And it creates this study committee to evaluate opportunities to establish a state authority to develop and administer comprehensive and affordable health benefits for all public sector employees in Vermont. It has 11 members who are each appointed by the entities they represent. So it has the state treasurer or designee, and then it has one member each representing the Vermont State Employees Association, the Vermont NEA, the American Federation of Teachers, the United Electrical Workers, the American Federation of State, County, and Municipal Employees, the Vermont School Boards Association, the Vermont League of Cities and Towns, the Vermont State Colleges System, the University of Vermont, and the Department of Human Resources. It directs the study committee to consider certain topics that you see in a list and produce a report regarding the potential for establishing the Public Employee Health Benefit Authority, or some other name if you prefer, to provide and administer health plans that would meet the healthcare and wellness needs of Vermont's municipal, state, public school, and public college and university employees and their dependents, including addressing all of the following: the manner in which health benefits are provided to public employees in other states, including Oregon and Washington, the similarities and differences in the level and scope of coverage provided by current plans offered to public employees, the similarities and differences in the current service or contractual agreements negotiated by public sector parties with commercial health insurers, third-party administrators, and independent clinical and analytical vendors, uniform design, coordination, and administration of medical and pharmaceutical health plans, care networks, wellness initiatives, and medical privacy protections, uniform standards and protocols for contract review and negotiations with hospital facilities, non-hospital healthcare providers, commercial health insurers, third-party administrators, independent clinical and analytical vendors, and pharmacy benefit managers, streamlined auditable processes to confirm the integrity and accuracy of billing from and reimbursements to hospitals, non-hospital healthcare providers, and vendors, opportunities to secure substantial and sustainable cost reductions for employees, employers, and taxpayers, monitoring and management of fiduciary risk, governance structures for this Public Employee Health Benefit Authority, deliberative processes and equality of decision-making by employer and organized labor representatives, as well as staff positions, member and patient advocacy and problem resolution for employees and employers, uniform standards and systems for collecting, analyzing, and securely transmitting data on clinical utilization, quality of care, and other essential metrics to support health benefit plan management and vendor needs, opportunities to expand participant access to primary care, mental health, and community-based healthcare services, redirect care from hospitals and emergency departments to less costly settings, and improve chronic disease management and medication therapy adherence. Finally, alignment of the Public Employee Health Benefit Authority operations and health benefit plans with the transition to reference-based pricing, global hospital budgets, and regional care transformations directed by act of the General Assembly, including, and it mentions a few around Green Mountain Care Board's prescription drug cost regulation and the outpatient prescription drug caps and the various provisions on reference-based pricing, global hospital budgets, and other provisions from last year. It also requires the study committee to provide recommendations on a detailed blueprint with timelines to design, build, and launch the authority. The need, if any, for independent consultants or advisory personnel for establishing the authority and going forward to support its mission, whether on a regular or intermittent basis, and the projected costs of creating and annually funding the authority.
Leslie?
So this has gone by fast, so I'm sorry if I didn't see it.
Okay.
But I'm looking at who's on the study committee. And at first I didn't think it dealt with any clinical issues, but as we kept going, it looks like they're talking about quality of care and opportunities to expand patient access to primary care and stuff like that. And I don't see any clinicians on that list.
I don't believe there are any clinicians.
Okay, so I didn't know. So I just want to understand if maybe what Kay and Jay are asking don't really have to do, don't require clinician input. I'm not sure. That's what my question is.
Great question.
So throwing that out there. I didn't want to miss something or,
No, I don't think, there's still more to come, but I don't think it's
Okay.
specifically addressed.
oh, that's I'm throwing that out.
Karen, did I see you?
Oh, this, I need a question.
Okay, so then it has this report coming in by February 15th of 2027, coming into the General Assembly and the governor. It gives the study committee the administrative, technical, and legal assistance of the Office of the State Treasurer and allows them to engage the services of one or more consultants or firms to help them facilitate meetings and public hearings and prepare the report. And then there was language in the bill as it left the Senate Health and Welfare Committee. This is from the Senate Appropriations Committee changed to the extent funds are made available for this purpose. Meetings, it has the treasurer or designee calling the first meeting to occur by August 15th of this year. State treasurer designee is the chair. Majority of the membership constitutes a quorum, and the study committee would cease to exist shortly after submitting its report. Requires the study committee to schedule public hearings, both remote and in person, to allow public sector employers and employees an opportunity to share their healthcare needs and concerns with the study committee before they issue the report. Requires commercial health insurers, third-party administrators, VHI, and clinical and analytical vendors serving the public sector to provide full and timely access to the study committee with appropriate non-disclosure agreements in place as needed. To the service contracts or agreements with the relevant public sector entities and any data that the study committee requests, including claims, actuarial, financial, and other data. And finally, it specifies that the members of the study committee will not receive per diem compensation and reimbursement of expenses for their participation. Then we get to a section on critical access hospitals and Medicare outpatient cost sharing, which I think is an issue this committee has spent some time on a month or so ago. This would direct the Green Mountain Care Board to convene a working group comprising representatives of the board, of VIVA and BFR, of critical access hospitals, of health insurers that offer Medicare supplement insurance policies, and of the Office of the Healthcare Advocate to develop recommendations for ways to mitigate the effects of a federal requirement that Medicare beneficiaries bear financial responsibility for 20% of the amount charged for outpatient services delivered by critical access. And it has by January 15th, 2027, the board provide the working group's recommendations, including the projected impact of each recommendation, patients, critical access hospitals, and premiums for Medicare supplement insurance policies and the state budget to this committee, the appropriations committees, and your Senate counterparts. And then it specifies that the Green Mountain Care Board shall not address or attempt to address the effects of the federal Medicare cost sharing requirements for outpatient services delivered by critical access hospitals through the board's hospital budget review authority in fiscal year 2027 budgets. So the board should not try to address this in budget orders, but let this work group do its work. And the act will take effect on passage.
A lot of stuff in there. Any questions for Jen on language? Okay.
Let's
Some.
start. Take it from the top.
So we're just gonna sort of do some high level overview testimony on this bill. Spoiler alert for anybody sitting around the edges, you're probably gonna have to come back as we start digging into it, so. It's not school break, like it was last year. Peter, want to come up? Or yes, last week. Seems like last year.
Thank you, Madam Chair. Peter Trombley, Director of Legislative Affairs, Office of the State Treasurer. It's great to be back with all of you on this hot afternoon. As you just saw in the walkthrough, S190 would direct the Treasurer to chair a study committee and direct to staff a study committee to look at establishing a public health benefits authority in the state of Vermont. We, appreciate the charge. We think this is a worthwhile topic, and we'd like to be helpful where we can. However, as I think you all have seen, the scope of the study is quite substantial. There are 11 members of the committee, quite a bit of data sharing that would need to be facilitated, 12 bullet points that would need to be addressed in depth across multiple deliverables for the legislature. And at present, we feel that the study as it passed out of the Senate is, beyond the capacity and expertise of our office to do alone. The bill does give us the authority to hire consultants to aid in the executing of the study. However, the Senate passed budget only appropriated $50,000 for that purpose. After consulting with a variety of individuals and consultants that we already have in our office across the actuarial, legal space in particular, and benefits consultants as well, we feel that properly executing this study would cost approximately $325,000, so substantially more than is made available to our office in the budget. As such, we would like to offer some suggestions that we think would allow us to scale the scope of the study to whatever appropriation emerges from the budget process. 3 changes in particular that we might like to see. One is simply to move the delivery date of the study report from February to July of next year, give us a little bit more time to complete the drafting. The second would be to make the 12 outline bullet points in the study optional instead of required, so that we may consider the ones that we feel are most pertinent to the final product, as well as, give the scope that certain of those bullet points deserve, the attention rather, that certain of those bullet points deserve. And the final would be for the committee to consider other entities within and without state government that might have in-house expertise that could be used to aid our office and reduce our reliance on paid consultants. I've not had in-depth conversations with any of these entities, so I wouldn't want to volunteer anybody without talking to them first, but it could be worthwhile for the committee to maybe get testimony from the CARE Board, perhaps the Department of Financial Regulation, about what, if any, capacity they might have to assist in executing this study. And I'm happy to answer any questions.
You'll send us those in writing.
Yes.
Any questions for Peter? Was the treasurer's office involved at all in putting this in this bill? Or was this just, hey, they threw the treasurer in?
We did not ask to be charged with this study. We were asked if we could complete it, and we feel that we, have the ability to do so, though we will need more assistance than
But you didn't ask for a study.
We did not ask for this.
Okay. Yeah,
I guess-
Leslie.
So I don't know if you know this, but then why do we know, I guess we need testimony about why that was a good place or?
Let's ask every person that
That's what
testified.
I'm
Maybe
saying.
we'll find out where it came from.
So where did this come? It did come from you. That's what we know so far.
Yeah, I'd encourage the committee to hear from members of Senate Health and Welfare. I will say our office does do similar work. At the moment, we negotiate the health insurance for retired teachers. And we do work with benefits consultants throughout that process. So we do have some in-house expertise on these topics and some capacity to address these topics, but not quite enough to really fully meet the scope of the study as passed.
You may not know this, and I really don't know. Was there ever a time where all the public employees were just, I don't know, in standard health plans?
I don't know off the top of my head the answer to that question.
We'll ask. With everybody else. Thank you.
Thank you. I have to depart, but folks know how to reach me. I'm happy to be back.
Thank you. So we're gonna go to Elena next.
Hello, thank you. Elena Barabee, Director of Policy at the Green Mountain Care Board. I'll try to keep it high level and I'll send you my notes. So I'll just go section by section and happy to stop and answer any questions. So just to back up, we submitted some of the original content for this bill as a means to kind of ensure that we were moving forward with reference-based pricing while we were working on developing our rule, which, as I think was mentioned before, because of the contracting process and kind of the state requirements around, going out for a competitive bid and creating the rule and going through a public process, we really didn't see a way to fast track it and do anything, sooner than FY28 or fiscal year 28. So we came prepared with some ideas of what we thought could really advance this program and do it in a way that prioritizes the Vermonters that need the relief most. So that's just background. I want to make sure everyone knows. So section 1, so this mandates, I think I won't kind of reiterate what it's supposed to do, but really focus on our priorities here. So we support this section. This is more of the reporting section, but with 3 adjustments for clarification. So the first one is that we'd like to clarify that this mandate applies to all new and existing contracts, so even including evergreen contracts. So those that don't expire, that keep going, we want to make sure that those are also subject to this language. We'd also like to clarify the scope of the collaborative process, which I think came up a little bit earlier, or consider removing it altogether. I think the goal here is to make sure that we're including all necessary services and items. Hospitals right now already produce and publish all of their rates for all their items and services in accordance with the price transparency rule, which is a federal requirement. So this would just be adding kind of one additional lens with which to look at that reporting.
And where's that?
That is page 2, line 5. Number 3 in this section, we'd like to clarify the actual paid amount for critical access hospitals. That's page 2, line 13. Critical access hospitals are paid on the basis of cost plus reimbursement. So this requires settlement at year end. So we want to be clear, this is based on their interim payment. If we had to wait for them to incur an entire year of expenses, we'd be looking backwards. And this is really meant to be a program that looks forward and sets clear expectations for all parties involved. So that's section 1. So I'll pause there and see if there are any questions.
No questions on this?
Section 2. So I think there are a number of questions in this section. I think this is a section I feel strongly about. So we support this section and with minor adjustment for clarity. This establishes a hard ceiling on hospital reimbursements to drive down insurer costs and in turn lower premiums in our most vulnerable markets. People on QHP plans would likely become uninsured without access to these plans, which currently pay some of the highest prices amongst many plans. The estimated impact to hospital budgets in fiscal year 27, we've estimated at 85 million. This translates to an estimated reduction in premiums for this market of about 14%. And that's really important because we've seen substantial growth in this market in these premiums relative to other states. We are the highest cost state for these plans. And it's, some of the highest cost plans compared to other commercial options. And based on the Nashville Hospital cost tools, this is very preliminary. We looked at kind of that break-even point. So what rate would hospitals not make any money? And that is at when hospitals are reimbursed at 112%. This is just an estimate. We're still digging into this. But this 250% that we've put forward here is much higher. But again, we wanted to focus with the QHP market because it allowed us to kind of take a small calculated bite, target it to the most vulnerable Vermonters, and make sure that we're kind of still addressing a comprehensive approach to this program and not just kind of creating piecemeal. Having the whole insurer perspective and a whole provider perspective is really important for being able to scale this program moving forward.
You said Nashville has a target of 112%
So we used their cost tool.
across the country.
This was just for Vermont. So again, we took their cost tool and focused on hospitals in Vermont and said, what would the break-even point be? At what break-even would we get? What percentage of Medicare would we get? And that was around 112. Based on our preliminary estimates, we're still, like I said, evolving that. But I think that gave us some kind of directional feeling that this, the 250 isn't overly aggressive. The 250% is also in line with what other states have done. They use a different reference point, so around 200% of the fully loaded amount. But many have been looking to us and really excited about this this Medicare standardized base rate. So that is equivalent to what other states have done.
And capping 250 is 85 million, you said?
85 million for the 27 fiscal year.
And I know it's preliminary, but it's not 112.
No.
It's not like it's going to be, preliminary, got 112 and it end up being 500. And we're talking about capping 250.
Yes.
Okay.
Okay. I think the other important thing to note is that, savings to this QHP market are guaranteed to return into the pockets of Vermonters. Because the board regulates these plans, we can ensure that any reductions in price are translated directly to premiums. I think once you start looking more broadly at some of these other plans that exist outside of our state, we can't guarantee that Vermonters are actually going to feel the benefit of those reductions.
What's the mechanism for that? I'm really curious.
So we have the rate review process at the board where we oversee and have a whole process around rates and can have conditions and
You can make conditions that
so I'll have our legal team can weigh in exactly on those conditions. But yes, that is the mechanism we have to do that work.
that was one of my biggest questions about this is how we ensure it goes to individuals. Thank you.
You said 85 million in your regulatory domain. You also do hospital budgets.
Yes.
Do we have a box we're working in that we think that hospitals would be able to withstand the loss of 85 million?
So that is a great question. So some of our estimates come back. So if you look at their total operating revenue relative to this 85 million, it's usually under 3%, sometimes around 1 or 2% per hospital. So it's really not a huge, in the big picture, a reduction of their overall revenue.
Do we have a sense in what hospitals would, we often talk about eliminating critical access hospitals, and do we have an idea of where prices are at various hospitals in relation?
We do. And so those,
So who would this affect, I guess?
yeah, so some of them are affected more than others, and I can kind of come back. I want to be comprehensive in my answer, but some hospitals, everyone is affected, but some are affected more than others based on how high their prices are currently. So if they're very high, coming down to 250 will be a bigger jump than those that are already kind of have lower prices, they presumably won't have as much work to do.
I don't think this is related, but I don't want to just assume. So if this were to be put into place, there are still people on the QHP who receive subsidies.
Mhm.
Would this affect that subsidy that they would receive?
Yes, so any amount that would come down, they wouldn't receive the subsidies, but I think there's already a huge, I think it was at 5,000, more than 5,000 lives just leaving because it's very high. So even with the subsidies, not addressing prices, they're incredibly high. So in this section, we just have a couple of clarifications. We'd like to clarify the Act 55 or the outpatient drug cap that you all passed last year. Thank you very much. Remains in effect and is excluded from the 250 cap. We don't want prices for, really important drugs to increase relative to where they currently are. And then we want to clarify that this cap starts in January 1 of 27, beginning plan year of 27 for QHPs in 1 quarter into the hospital fiscal years, because our QHP fiscal year and our hospital fiscal years are not aligned.
Oh, back to section 1 a little bit.
Sure.
What do you think realistically it would take for hospitals to achieve being able to do their own sort of referenced pricing? I mean, so not out of reference, but like to align things with Medicare.
So hospitals already know what they're paid by Medicare. And these rates are published. The base rate that we've been talking about is published. I think for critical access hospitals, their interim payment, they know that because they're using it to bill. So I don't think, it's just a ratio, if you will, of what their prices are relative to an amount they already know.
Like a spreadsheet calculation.
I would hope so.
Okay.
Yes. So should we move to section 4? So this is around reference-based pricing for public employees. We are neutral on this. We produced a report already on this topic for Act 113 of 24. And we've actually already included these populations in the next release of our price transparency tool, which will align with our reference-based pricing approach. So, you can add it here, but I think it's kind of redundant to work we already have in place. Section 5, hospital outsourcing. So this version of this section is really only a reporting exercise. And I think a previous version had kind of more direction to make sure that any outsourced revenue is subject to the board's regulatory price caps, as we've been talking about reference-based pricing, but also any budget caps that they establish through the budget process.
We will have the board back on this.
Topic. Okay.
I know that it has just been brought down to what it is, but if I recall, it was the hospital budget process in the last year that sort of highlighted what was happening.
Yes.
Okay. We'll delve into that. So I look forward to having someone back.
Wonderful. Section 6, we are neutral. We prefer the original broader language that excludes bargaining power across GMC regulatory decisions, but understand that there were, there was a desire to focus on reference-based pricing. So, we still feel that the broader version is more appropriate, but we're okay. So the broader version just carved out any of the board's regulatory decisions because this presumably gives providers an opportunity to bargain and can slow down the process without really any additional benefit to anyone. Okay, and then section 7. So this is about appeals. So we support, no changes there. I've lost my page. Okay, section 8, we support this, no changes necessary there. And we've started this work and are working well with our partners at the Agency of Human Services to kind of put this federal funding to use. We're very excited about the work we have ahead of us there and bringing more accountability to some of these issues we've been talking about. Section 10, the Public Health Benefit Authority study, I think you've just spoken about that. You know, we're neutral. We're happy to help if there's an opportunity there. Certainly need to think about resources, but, you know, we don't have a strong opinion either way. Section 11, critical access hospitals. We do not support this section. We've already convened a work group, and we've, you know, done a lot of digging. We actually have a pile of emails in my inbox I have to go through with additional information, and we're going to continue to convene an engagement process. We have another meeting scheduled for May 13th. We've hosted already a series of discussions and requests for information to really try to understand this issue. And, you know, if we find a solution, we don't think we should be tying our hands. You know, the goal is really to make sure that hospitals are kept whole, and that we're just not shifting costs to Vermonters when Medicare can and should be paying the bill.
Could the board, someone at the board provide, Tasha, a link? I would like to post on our committee page, a link to the comments you're currently receiving.
Yes.
I know you have a page on your webpage,
We're happy to.
but it's a little hard to find.
Okay.
Anybody who's.
Link. All right, we'll do that. Okay, and then I think there, in the previous version of this bill, there was a section on our audit authority that kind of created a parallel authority to that of our partners at DFR. And so we would like the committee to consider adding that section back.
Can you speak more about that?
So currently DFR has the authority to audit its regulated entities. We would like to have a similar authority. We believe that if we kind of issue a budget order or establish, you know, a regulatory threshold, that we should have the ability to go in and ensure that our regulated entities are compliant. You know, I think some of the earlier discussion was around the costs associated with this kind of audit authority, which is, I think, in that sense different. Like, we're not going in as a CPA or, you know, reproducing audits that are already kind of in place, but rather auditing on behalf of our, you know, regulation.
Any other questions?
Yes.
The last page, page 18, but last B, why is that so aggressive? Like it actually says, the Green Mountain Care Board shall not address, and to me, if we know that Vermonters are being charged more for being in a small hospital, we know that, and then I know you guys are working on it, Green Mountain Care Board, and once you find this out, which you probably will, from what I can gather, from what I've been reading, you're just not supposed to act on it, or?
I think question of who the language came from.
Yeah, where did that language come from?
That doesn't not come from the board.
What's that?
That's the,
The hospitals don't want you to act on, is there a rationale behind that, or just?
Let's ask.
Okay, all right.
just so you, they'll say.
Okay, thank you.
Anything else?
How many people? You can send a copy.
I will send a copy of my notes, yes.
Thanks, Elena.
My pleasure.
Thank you. Hi, Commissioner Sampson.
That's in my pocket.
You know, I have to say, you always complain that it's really hot in this room, and I'm never hot. It is hot in this room.
People in here.
You are right, it is.
Yeah, how you doing?
You didn't even have to say
I don't have the jacket on. I've got the tie to swab.
it. Basically, a t-shirt, I would
Feel like I'm in Baton Rouge.
have.
Thank you for having me, Commissioner Kai Sampson from DFR. I'll just go through our reaction to S-190, which is really primarily on the focus on the QHP. So we support reference-based pricing. We think that's a great tool to benchmark and reference what hospitals are charging, provide greater transparency, and certainly when acting upon controlling hospital costs, I think reference-based pricing provides a really great metric in terms of, let's tackle costs above this first, or So it's just, it's a great tool. So no issues with what section 1 is aiming to do, which is to really fast forward the implementation of that. Section 2, however, I want to spend some time on we disagree with that focus on the QHP. So the QHP is a little over 10% of Vermonters. And about 25% of the commercial market, which, so a quarter of the commercial market. So that includes, if you look at VHI, state employees, municipal, and then businesses, employers that are offering health insurance off of the exchange, that's 75%. 25% is in the QHP, among again, outside of Medicaid, Medicare, and our uninsured population. So
Wait, I'm sorry. 25% of the commercially insured, you're saying is?
Yeah, and I bring in,
Some of the,
yes, 25% of the commercially insured. And when I say commercially insured, I essentially mean everything but Medicaid and Medicare.
Okay.
And if you look at the total Vermont population, it's about 10%, a little more than 10%. And roughly split between small group and individual. Not exactly, but to the question earlier, about 80% of the individual market is individual QHP is subsidized. So I do think the committee should understand, and I don't have an answer for you, not our bill, and it would take some doing, I think, but I think the committee needs to understand if we're plowing large amounts of savings into the QHP, how much of that serves to simply reduce subsidies with no net impact on what a Vermonter is paying. And the problematic mechanism there is that the federal subsidies are on the individual market are expressed as a cap of percentage of income. And so we have very high costs, no doubt about it. So if your cap computes to $800 a month, $300 a month, let's say, and the actual cost is $800 a month for the plan, and this plan comes through as written, reduces 800 to 600, guess what? You're still paying 300. The only difference, so some portion of this savings will go to reducing subsidies, federal subsidies. Now, I agree with what you may hear and what we've heard before, which is we shouldn't define our policy by we should not do a good thing because some of it will just not land in Vermonters' laps. But I think we need to know how much. So that's one of my concerns, one of our concerns. In terms of the cost of this, Blue Cross had run those numbers as well. And the Care Board had shared some of the detailed calculations as we had shared the Blue Cross numbers with the Care Board. And my understanding, and can be corrected if I'm wrong, is that the 85 million is computed not as a cap, but as a straight across. So it does not allow, but I think due to data limitations, they didn't have the ability to see who's above, who's below, and just haircut above 250. They just said, what if we set reimbursement at 250 across the board? And that was the basis of the calculation. So I'm told, which means that number is understated. And that potentially explains why the Blue Cross numbers come to 123 million. So we're in the ballpark because, of course, as the Green Mountain Care Board testified, the 85 million is not a full year number. So I think it's a 9-month number. So that does, I think it's like 113 under the Care Board's calculation. Anyway, don't want to get too mathy, but it's a big amount of money from the hospital system. And I think that segues into another concern, which is this has been pitched, so to speak, as a pilot, as a good place to start for reference-based pricing. We all know that the QHP is vulnerable and deserving of a break. I'll talk about other populations that are deserving of a break on healthcare costs later. But losing my train of thought here. Questions?
Can we have, can we get
Yes. Yeah, you'll get my notes.
I actually do.
Oh, sorry, it's a big amount of money.
Just about the QHP market.
Yep.
Okay, so I feel like you were just sitting across from here and we were doing talking about in 585.
Yeah.
How much of the individual, and I don't know if we know this. How much of the individual market do we think are people who just do not have employer-sponsored insurance? And it's their only mechanism for having insurance. And how many of those people are not offered insurance because their employer cannot offer insurance because they can't afford insurance in the small group market, and they're not large enough to be self-insured? And then I want to ask you about self-insurance.
Yeah. I don't know the answer to that question, but it's a good question, and I'm sure the numbers are that you're hitting on probably a pretty sizable population of the individual market. I just don't know the answers.
I mean, it just seems like we're really hurting the QHP market, which is actually driving people almost their last resort into the QHP market as far as like into the individual market.
I mean, there's a lot of dynamics there. It's not just cost. I really think that the committee should have a broker in this chair who deals with people, puts people in the exchange sometimes, puts people in self-insured plans, et cetera, or models what ICHRA looks like. Yes, they're a paid, advisor for benefits, but they are very much experts on how employers and employers navigate the highest cost, one of the highest cost environments in the country.
I think we have that on Thursday.
Okay, great. So yes, when I lost my train of thought, I was talking about the volume of savings that S190 delivers into the QHP. So our response or our hope is that whatever savings are appropriate, apply to everyone. You'll see that certainly must have been a discussion, because now we have studies on the impact to state employees and of implementing this to them as well. Rather than study it, why don't we just do this across the board? Act 55, pharmacy costs across the board.
What section is that? What are you thinking of? Which study?
Oh, it's
The public,
11? No, 10.
10? Section 10?
Oh, 4.
and 10.
Yeah, and maybe 10. I'm not quite sure what 10 is meaning to achieve. But,
You and me both.
what's really behind that? So, yeah, last year's board actions, DFR actions, and insurer negotiations that influenced 2026 rates, insurance rates, and reimbursement rates, what the insurers are paying the hospitals, made a very big difference in hospital revenue. I watched the testimony of Dr. Leffler in front of this committee, their current, upside downness. I think he testified a very shocking range of projected losses this year, in this fiscal year, and a current loss of $400,000 or $500,000 daily, and unanticipated current lower utilization. To give you a scope of the amount of savings that are in S190 focused all on the QHP, it's more than double what the Care Board's hospital guidance was. And so I don't I'm not responsible for hospital solvency, and the Green Mountain Care Board is. So I'm prepared to say the right number needs to be endorsed, determined, and backed up by the Care Board, which they've done. What I'd like to see is that that number of savings, if deemed appropriate and not something that's going to collapse something that we don't want to collapse, that should be applied to all payers or to all commercial insurance, including VI, which will have an impact on property taxes, and all of us, including the state plan, which will have an impact on all taxpayers who, and that plan is currently in deficit. There's a fund, a special fund or an internal service fund that I believe in the recent past had to get a general fund transfer to top it up. So the pain is pretty universal throughout in terms of the cost of healthcare. And I think the only durable and sustainable way to address that for everyone is to deal with cost of care for everyone who pays for the care, which includes all of us as taxpayers, property taxpayers, and all employers.
Do you have any indication on impact for rates if we did extend it to everyone? Elena gave 14% reduction in the QHP.
Yeah.
And I mean, would it be even noticeable?
It would be because it's only 25% of the commercial market. We estimate that using the same amount of dollar amount savings, applying that across all the populations we think it should apply to, it's more like 2.5%, 4% range downward pressure. So certainly every bit helps, but it's not going to make the news. My concern is, back to that volume of savings, is that what we pitch as a pilot, and will take care of employers who, of course, are struggling, property taxpayers, et cetera, that there's may not be juice left to squeeze in future years. And so we may expend all near-term available savings in the hospitals on just the QHP. I totally understand why this is on the table. But back to our conversations about the association health plans, about the Mike Fisher's valid concerns about the small group market and yours. I think a 10 to 15% reduction in cost in the small group will help slow the erosion or the migration of people out of the small group. It will attract some groups back into the small group. But I've talked to 2 brokers from different companies, both major benefits consulting companies in the state. And talking to other state regulators that have similar issues and deal with the exchanges, the federal changes in the exchange, et cetera. Strictly the decision between self-insurance and ERISA plan and staying on the small group is not just price. Price, absolutely. I want to see some savings. But it is also the ability to not pay an insurer for the risk premium. When you make an insurer take risk, they charge a premium. That's how they make money. As a employer, if you go self-insured, you're going to get an estimate on, you're going to want to put away this amount per month per person to cover claims. If you can beat that, that's in your pocket as an employer. If Blue Cross beats that estimate through their own wellness activities or whatever, or just good luck, lower utilization, it goes to Blue Cross's profit, which is nice for Blue Cross. But so employers are looking to not be paying that risk premium, have the upside of favorable underwriting results, and also benefit flexibility. So I mention all this to caution the committee that just even a price differential or improvement of that much is not going to save the QHP. We are very much open to a comprehensive study, and not a study to delay action, not a study to hunt this down the road, but to fully understand there are future federal risks around silver loading, around defrayal. There are much bigger problems than just price. And as you know, I want to further explore can age rating. I know age rating, limited age rating can be part of the solution to keep healthier lives in the small group as well. So we are very open to, we think we need way more information before and more options before a policy decision is made that leaves large employers and public employers with no savings, with the hope that this somehow, becomes this miracle moment for the small group. It will not.
Can you talk to us a little bit about, because we actually don't deal with it very much in this committee. It's more of a commerce thing. Like the self-insured market. What do you have to do to even become self-insured? And what do you, I honestly, I have no idea. How does someone just decide, we're not gonna buy health insurance anymore, but we're gonna become self-insured? What is the mechanism? Because you regulate like all the sort of levels along the way. How does that even work?
Well, we don't regulate all levels along the way because we are preempted to do so by the federal government, like referring it to ERISA. So Department of Labor's Employee Retirement Securities Act prohibits states from getting in the way. I'm not a lawyer, I'll use layman's terms, getting in the way of an employer who wants to self-insure. We do regulate stop loss, which.
Can you tell the committee what?
So if
Understand this.
yeah, so when you decide to go self-insured and you have 40 employees, 60 employees, whatever, it's probably going to be more. Certainly a large employer. Let's use National Life or Global Foundries, et cetera, most likely self-insured. They have such a you buy insurance to spread risk. Well, they spread risk because they've got, 1,000 employees or even 100 employees. But there's still the possibility that a major disease or just a bad trend really shocks them. They're told you expect to pay $500 per member per month, and all of a sudden it's $700 per member per month, 40% increase. So they will likely have a stop loss, which is essentially kind of reinsurance, a stop loss policy that says, for example, to the extent your claims exceed 130% of our estimated aggregate claims, this insurance policy will pay. So it protects you from extreme upside risk. And you can also have specific limits. You could say if you have any one employee who's costing you more than $70,000, you write that into the policy, then this will kick in all or some of the additional costs. So there's the specific, they call it attachment point for the aggregate. So that's a key piece to how does someone go self-insured. I'll once again say that that is a great question for a broker, and I'll recommend one. I don't know who you have coming in, but I have one who's a former regulator at HCA that I think would really give you a balanced perspective on this, particularly the difference between some of the policy considerations, which you are very sensitive to, and also the employer considerations, why they do it, and why certain things make sense and move the needle in terms of the decision between going into small group, going ICHRA, or going self-insured.
I get one testimony another time. But, yeah, did you want to keep going?
Let's see what else I got here. I do want to say that when we look at what's available, responsibly available in the system, obviously I know Vaz will be speaking today, I believe. Again, that is really for the legislature, the care board, to listen to testimony and decide. One caution is that and we know that the liaison that the care board put at UVM has been issuing public reports, and there is one coming that will talk specifically about cost savings at I want to say the network, but the UVM. I think they dropped the network.
They did.
One thing that you want to keep in mind is that there's a very important distinction between expense savings and expense savings targets at a hospital and what ends up becoming revenue reductions, which impacts insurance rates. So specific to the University of Vermont, Dr. Leffler testified to their current status of losing money every day. Certain level of expense reductions will be possible, will be called for, necessary to just break even, right? So the caution here is that as you hear, whether it's from VAS about their expense reduction goals across the system, or if it's specific to a liaison report on hospital expense reduction goals, those absolutely do not translate. They could, but they do not translate into, therefore, we can cut their revenue by the same amount. Just from an accounting mathematical point, they are currently already underwater and losing large amounts of money. Those expense reductions may only serve to break even or keep pace, or certainly a portion of them. So please keep that in mind, because it can become bewildering when you hear hundreds of million here, hundreds of million there. They could mean entirely different things. And I guess it is around that note that I am concerned that applying approximately, depending which numbers, right, 85 to 112 million of savings just to the QHP in revenue reductions to the hospital systems. My take is that is a big chunk. It may be the right chunk, but I don't see a lot of hope for spreading the wealth in year 2, 3 to employers and public entities. But big caveat, the Green Mountain Care Board is responsible for hospital solvency. They're also responsible for affordability. So we are in a position to take their word for what works without disruption. Although we're keenly interested in the VAS testimony as well. That concludes my prepared remarks.
I think I lost my train of thought. I was going to ask something about UVM and the network.
No, not.
I want to buy you some time with a little extra testimony.
Sure.
Part of the walkthrough, we talked about section 4, analyzing plans for public employee benefit plans. We have that data. Blue Cross can respond to it. I have it in my hand. Care Board has it. It shows different scenarios, the impacts to Blue Cross's savings, which we can then extrapolate to the whole market of going 500% as a goal to work towards across the whole system. What that would ultimately save if we got everyone there, that's 245 million in revenue, bankable savings to insurance rates. And then I'm sure you've heard that radiology and diagnostic imaging are particularly high volume and high price areas. Focusing on those two saves 172 million approximately in revenue reductions across the system. Specific to that, obviously, if we were to get what we'd like, which is to apply these savings to everyone, it can't be at 250. And again, it needs to provide the negotiations between insurers and hospitals and the Green Mountain Care Board, the room to calibrate that. But I think having a 500% cap across the board with guidance and target and reporting responsibilities by all parties. What's above that cap? What have you done to get closer to that cap? If you haven't, why? That's where I think this bill should fit. Kill enough time to think of your question.
I determined that, and I might have to have Elaine come back up. I have determined that I'm gonna ask every single witness this question. Is it just me, or is anyone else astounded that we're sitting here talking about capping something at 500%?
I'm astounded.
I'm astounded, yes.
Of what is essentially supposed to be cost of care, and that it is these millions and millions of dollars.
I am astounded, yes. I'm astounded that across a system, a cap as high as 500%, that there's that much service and volume to produce over $200 million of system-wide.
250% for the small little quarter of the market that you're talking about, $85 million.
The 200 mils across the whole system, the 85 is just the QHP.
Yes.
Right, just so I got that right.
Yes, but just capping something at 250% and
A little piece.
a little piece.
Can I
Yes,
follow up
of
on that?
course.
I guess my question is, why do you want to make the pain worse? Like, I think doing the QHPs initially will give us an idea of how painful this whole thing is gonna be. If you add in the others at the same time, do you risk collapse? I mean,
Great question. That's not what I'm saying. I don't want to make the pain worse. What I'm saying is that, yes, so 250 is in the bill as the right number to produce 80 to 100 million of savings with the QHP. If 80 to 100 million is the correct number to expect hospitals to extract from their revenue, take that number and say, what can we do system-wide with that dollar number? And that's where the 2.5% to 4% reduction, roughly, where we could land across the board for property tax, for general fund, essentially, VHI, employers, and QHP.
So you're recommending essentially sort of another little tool like we did last year with the ASP drug.
Yeah, that wasn't a little tool. That was a major.
This is
Why
not a
not
little
go
tool.
again?
Again,
Yeah.
is anyone else astounded that we did one little thing?
Right.
But
Well, and for-
that's what you're.
Furthermore, I would recommend that we continue to rely on some fine tuning by the Green Mountain Care Board. That's what I would want as a, if it's impacting our insurers, right? That generally a very blunt axe of at the statutory level of 250, boom. It's possible that Act 55, according again to UVM's testimony, is costing more than anticipated. That, we need to be open to the idea, we need to preserve the flexibility of the day-to-day regulators to react if that becomes the case and not sink a ship that we weren't ready to sink. So we are saying, don't make the pain worse. Enforce reference-based pricing, make it happen, hold people accountable to it, report on it, all the tools that it provides. But unless we're crystal clear on how much the system can afford, shouldn't be in statute. But a goal, a target to center everyone around, whether it's 250, 350, 550, 500, absolutely appropriate. But I think the flexibility needs to remain with the folks that are responsible for the solvency of these entities, which does include the entities I'm responsible for, because we want to see adequate rates as well, so that we don't have insurance issues. But primarily, I think the concern should be on system solvency and having an orderly, thoughtful right sizing of the system.
Yes, of course.
One other question, like, so I'm a state employee, I'm an nurse, so most people that give up a job will get insurance through their employer. And I heard you talking about, having a broker come in. There are times where the only option is to get into the marketplace. There's no other option.
Yes.
And for that reason, and because when I started at the state, we opened up the marketplace. It's important to me, and it's important to a lot of people that live in the state. For that reason, I want to save it.
Right.
So, and I understand where you're coming from. It should be more of a statewide savings for everybody if we can do this. I get that, but I think right now we're just trying to like save certain entities of our healthcare system, and the marketplace has to be one of those, in my opinion.
It needs attention for sure. So we probably differ on what type of attention when, but the issues and the issues coming down the pike potentially from the federal administration demand, I think, a more comprehensive.
And do you know something we don't know? Are we like, is the marketplace on the verge of collapse? So, are we throwing good money up something that's not
Is the
viable?
QHP marketplace on the verge of collapse? No, I think, but so defrayal is an issue that they've teased at the federal level, meaning we would pay for everything out of the state pockets that we offer on the exchange. I'm going to be very blunt, general about this. Not an attorney, I don't know the specifics, but essentially not just, going back to I think the original essential health benefit, anything above that's mandated, we would now have to pay for, is the worst case scenario. Did I get that generally right?
I think so.
Okay, so that's out there. Silver loading, disallowing silver loading. I don't know if you've been down that whole rabbit hole.
Oh, yeah.
Okay, good. Like that is under threat. So there's a lot to think about. And if both those things happen at once, maybe the state budget would collapse. Not the QHP, but I shouldn't say that dramatically, but there'd be a lot of consequences to, we'd either have to, anyway, that's not what this testimony is
No,
about,
it's
but
not.
but I hear you,
But
yes.
while we're on this subject, one follow-up question is, I know Blue Cross Blue Shield has been talking about like revamping their menu on what they're offering in their QHP. Would that be something they would still be able to do while this is going on?
I'll let them, they're
Okay.
coming up next, but.
All right.
But I think that's part of that is a reaction to the price environment we have,
Mhm.
is to offer more options, be creative about,
And
serving
your
folks. And
things,
I
yeah.
agree. Many folks on the QHP do not have options. I'm not insensitive to that,
Mhm.
but I do think there are multiple businesses out there that don't even have the option to go on the QHP. Maybe there are 110 employees. They're facing the same costs, similar costs, cost of care. And absolutely, I'm not being melodramatic, but they are making choices about not giving raises, laying people off, not expanding their business, not making a hiring decision that they want to make because the cost of healthcare. So I'm not in the business of ranking who's more deserving. And I'm not, I think everyone's suffering, and I think savings plans, we're deviating from the norm by focusing just on this QHP.
Constituencies, Leslie?
Thank you. So what I'm just curious about section 4. And what I'm hearing you say, and I think I also heard you say that section 4 is redundant. And you're saying we don't need a study, just do it. So are you saying take out section 4, or would you recommend other language?
I don't want to answer that right now because I'm not exactly sure. I have a summary of the bill, and I'm not exactly sure what the motivation and the goal was, the true motivation and goal. I think I would suspect that maybe it was, hey, we know we're not sharing these savings broadly, so we'll throw them a bone and study it for them. But of course, we've looked into that. All Blue Cross has run some numbers, and that 500% metric would save around $40 million for VHI. That's a rough number. I had to do some division in my head here for the state of Vermont.
So does that mean that when?
So those claims have been analyzed. I read the summary and it's like analyze the
That's what I'm
claims.
curious, is this has already come through the Senate, so it apparently didn't come up in the Senate, or did you not test it? I'm just curious about this process.
I see our Blue Cross representative nodding his head, so maybe he can address that when he's up, but.
But I'm thinking from a DFR point of view.
DFR, I don't think we testified at all on this one. No, things happen quick, particularly at the end.
Okay.
It left, S190 left the Senate with an estimate of 50 million cost to the QHP plan. Now it's 85 million, and I'm concerned that that might be on the low end.
Okay, I just want to understand the process of what we're looking.
Yeah.
Okay,
And full disclosure, I said this a couple times, 190 has just been sitting there because a lot of people are running like numbers.
Yeah.
So it left the Senate very quickly. Karen,
Not quite know where to start because I feel like I have still so much to learn about this. But, the idea that the QHP folks they're the ones that are sort of left out in the cold. There's so many other big plans that cover health insurance. And maybe they're working for a nonprofit, maybe they have a small business, who knows? They're not only struggling to not provide adequate health insurance for themselves or their employees, but they're also paying for everybody else's. So
I'm sorry
because they are a taxpayer, they
Oh, I
are
see.
paying for
Sure.
education-related health insurance that
Yeah.
they're particularly bargained for on the state employees and so forth. And so I really love the idea of focusing or concentrating the relief on this especially burdened group. So I'm just gonna say, conceptually, I like that. And then you would actually see a real impact and result, that not so diffused and distributed and everybody shares a little bit, but doesn't really make much difference. But I didn't understand your point about that this could only reduce the subsidy. I mean, some people don't have the subsidies in these.
77% on the individual side of the QHP have a subsidy.
But like if you have like a health insurance plan provided by your employer,
Yeah, no subsidies.
no subsidies there.
Correct.
And it's very, very painful. It's like, those are nonprofits. It invades their ability to do mission work. So, but anyways, so I was just trying to understand and the mechanism, this would only reduce subsidies and not really have the impact we hope for.
Yes.
Could
Yeah,
you
so-
explain that one more time?
Sure, yeah, so that's only on the individual side,
Okay, got it.
where almost 80% of the enrollees get a subsidy. The way those subsidies are structured is, it's based on your income.
Subsidies that remain.
So what's left?
Yeah.
It was higher. I think it was close to 90% before we lost that other tier of subsidy.
Mhm.
But the way those subsidies function is they are essentially we're going to look at you, representative, look at your income and say, because your income, you should pay no more than $300 a month for insurance, regardless of whether that insurance is $400 or $1,400 a month. And so what I think we should all know before we deploy, around $100 million into the QHP. Oh, well, so stay back on that. So you're getting a $1,000 policy right now for $300, and we reduce QHP rates by 15%. So now it's $850 for your policy. You're still paying $300 because you're capped out. The way that subsidy works is you are capped as a percentage of income. So what that means is when, the question I'm asking, okay.
I was gonna
Thank
say,
you.
you're doing a great job, but I wanna table it because we will have the healthcare advocate and he loves nothing more than explaining all of this.
So that was helpful, thank you.
Most people will, the effect on the QHP with the subsidies. Sure. Yes. Any other questions? All right, we're not taking a break today. We're powering through. I'd like to finish up here. It's warm and I don't think we should belabor this anymore.
Let's go.
So let's go. You're all set.
Can you pass the note?
Yeah, oh, wait, a notice being passed.
Mary testified on.
Yes, Joe, for the record, Joe Valenti, Director of Policy, DFR. Just to correct the record, I went back and looked. Mary Block, our Deputy Commissioner for Insurance, testified on February 11th. That was the original version of the bill that did not have these specific targets.
Oh, that's 190 in the Senate.
Right, so we, in general, we support the concept of reference-based pricing, and so that would be consistent.
Thank you. Courtney, come on up.
Hot seat, Courtney.
Yeah. A little nicer by the window. Thank you, Courtney Harness, Blue Cross and Blue Shield of Vermont. Nice to have a few folks to draw on for my remarks. I did send 3 documents in for the committee that I think were posted. Mostly wanted to make sure you all had much of what was shared with Senate Health and Welfare, as well as what has been shared with many stakeholders in reference to reference-based pricing. So I'm not going to go through all of those documents. The purpose of those documents is for you all to have some sightline to what some of the current prices are for some of the highest priced services that we have in the state of Vermont as we go through this discussion about the importance of, and Commissioner Sampson did a really nice job of talking about the importance of price reduction and downward pressure on premiums. And I think important to note as we talk about Act 55 as our first foray into reference-based pricing, we don't need to test this. We know that it works. We know that it works very well. We know that it produces immediate savings, and we know that it produces immediate downward pressure on premium. I think we testified that we estimated Act 55 alone to put 4% downward pressure on premiums for 2026 rates during last year's rate filing. So a few things that I want the committee to be aware of relative to what you've heard us describe already on labs and radiology. So if we go all the way back to December 3rd, I think the all legislative briefing, you might remember slides that got posted today being shared then. We shared those same slides with the Green Mountain Care Board in October. We shared the same slides with every hospital CEO in the state in early March. We have taken some of those numbers, and it's important for me to make sure that you all hear me say, we heard you. We heard you, we've heard Vermonters, and we've made changes to how we operate and how we do business because of that. What you see in lab and radiology with 300 and 500% of Medicare, is that still way out of bounds? Absolutely. Way too high. And every single hospital in the state got a letter in late March saying what that would look like for them specifically to start our negotiations. We heard this committee very clearly say that we need to do a better job of negotiating on these prices. We typically start that process in October. We started it in March this year. We think that reference-based pricing is a very impactful tool to move the needle for all Vermonters. So we also, and I think one of the representatives here mentioned it, we submitted several plan designs for the QHP with the intent of more affordability for Vermonters. We haven't done that in a while. That's important to note. So I say all that to say, when we started off the session with this bill, none of this language on reference-based pricing was in there. And so we've come a long way, and we should be really happy about how far we've come on this. These are meaningful savings. And it would be crazy to tell you that this is a bad idea. What we will tell you instead is, and you've heard me say this before, so we've heard the word redundancy a few times, so sorry for it. Our mission is to make healthcare work better for all Vermonters. Our statutory obligation is to all Vermonters. I think I could be wrong, but 18 VSA 9371, which is related to healthcare transformation, requires that we act in the best interest of all Vermonters. So when we think about reference-based pricing and Act 55 and the testing that we've already done on it, we know that it works. We know that it works. We know that Vermonters feel the effects of it. And we don't need a small sample size. All Vermonters need this relief. The QHP is 10% of Vermonters. Is it the most vulnerable? Maybe. Might it just affect subsidies? I don't know. Might it be $85 million? I don't know that either. I don't think the intent of, going to make a broad assumption, but I don't believe the intent of anyone in this building is to raise any prices at hospitals. I think that might be what we have with an $85 million number, because our estimate is closer to 140 if we capped all the prices below 250%. So that means hospitals don't elevate prices. And I'll repeat something that our new CEO said recently. If you think we have a healthcare crisis now, wait until 3 hospitals go away. Wait until 5 hospitals go away in December. $140 million in one swoop might do that. And we don't know, we haven't studied the QHP enough to know if a 14% reduction will bring anyone in or not. I think it's important to know that we don't know what we don't know, frankly. This isn't about us suggesting or recommending that we start with labs and radiology. We're saying after Act 55, those are the next 2 highest priced lines of service with the most impact. I can tell the committee that we put those numbers in front of every hospital. It was a total of $103 million.
That's Blue Cross Blue Shield.
Yep. And almost every hospital said it was too much. That's part of a negotiation, right? Like that's where we negotiate. But part of our responsibility is to make sure that our members have access to healthcare where they need it, when they need it, at a price they can afford.
So what was too much? I'm sorry.
$103 million to bring labs and radiology to 300 and 500% of Medicare.
Okay, so I'm looking at your slides and just
Yeah.
trying to make that connection. Thank you.
So you might have outdated numbers. So Commissioner Sampson did suggest also as it relates to studies, we already know the effects of reference-based pricing on VHI, VSEA, and any other entity that we provide insurance for. So I would suggest that we don't really need to add that in to this bill. I think we've already given DFR numbers on the savings to VHI. If there was a 500% Medicare price cap, it's substantial. And same with state of Vermont, real savings. And by the way, when we do that, QHP also gets savings and not a small amount. So my whole point here is we can't sit here and say we don't support improving prices in the QHP. It would go against our mission. It would go against our obligation on a number of different levels. What we can say is there might be a different way to achieve savings for all Vermonters, to hold us accountable to better negotiations, to hold hospitals accountable to reductions in price. Commissioner Sampson said it, and I can't say it any better. Expense reductions at hospitals do nothing to premiums. Not a thing. You can cut 100 people at UVM Health and it won't move premiums at all. Cost of services and cost of care has to be reduced to do that. So if it's 10% of Vermonters in a marketplace that we don't really understand, that has a handful of potential federal hiccups and interruptions coming, it's really risky.
I'm not sure I'm understanding what you say is risky. I'm sorry, I'm not.
Sure. So I'll give an example of several of the studies that we've talked about in here, other committees. Age rating is one, silver loading is one, subsidies is another one. I would suggest that plan design in and of itself is an affordability lever that we think we could pull in the QHP. There's 7 or 8 factors that we think we need to, and not we think we need to pay for someone to dive deep into the mechanisms and the mechanics of the QHP to say, here's what needs to happen relative to age rating, to silver loading, to plan design, to out-of-pocket maximums, which we've talked about in this committee. And when we bring all of these things together, here's how you can do this to affect affordability without touching a price at a hospital. And that's a very real outcome in the QHP. And I think, this is our opinion, if we couple the study of the QHP, and by the study of the QHP, I mean a study of the 7 other studies we've talked about this session, to figure out what levers to pull in here next session, then we get the benefit of the affordability from the mechanics of the QHP, along with the benefit of other price reductions from reference-based pricing. And we probably end up somewhere pretty close after a few years. I don't know that that's fact. We haven't done the study yet, so I wouldn't be able to tell you with any certainty that that can or can't happen. I wouldn't be able to tell you that if we drop to 250% of Medicare, maybe the QHP goes from 65,000 to 200,000. It's a possibility. To Commissioner Sampson's point, I haven't talked to one person that thinks that a 14% reduction of premium in the QHP will bring a substantial amount of people into it. And more than that, I haven't talked to one broker that said 15% is enough to move their clients into the QHP. So again, I think that brings up a whole different set of issues related to brokers and all of those things. But here's what I think. A lot of the work in this bill is already done. A lot of the data already exists. And a lot of agreements have already been made about where we think we put out contract letters to hospitals. And then this ended up in a bill immediately after. And every single hospital said, well, we can't do what you asked us to do because we might have to do this too. And we have to do this too. There's no way we can afford it. So we're really sensitive right now to how this plays out and how this comes to life and how it exists. We're trying really hard to work with all of our regulators, all of the hospitals, the healthcare advocate, our members, 200,000 folks, to figure out a solution where they can feel some relief immediately. I think the playbook from Act 55 is spot on. I think we can target a couple of high-priced services. And I think every Vermonter everywhere in every town that goes to any hospital can feel the relief. And that spreads across the QHP and any other market segment.
Karen, so or you're projecting a 14% reduction in the QHP.
That was another number shared earlier.
Right,
Yeah,
and so it's like, I heard 10% of the people are in it, but 25% of the commercial market.
Yeah.
So, do you have a similar, or does somebody have a similar percentage reduction if reference-based pricing is applied to state employees system, health insurance system? Same thing for folks insured by schools. What does that look like? If it's, 500.
Yeah,
You say this information.
yeah, I'd be happy to tell you a dollar amount. And I can tell you a study was done on reference-based pricing with VSEA. And the most recent year with a full estimate was 2022. That number at 200% of Medicare was $89 million for VSEA. Again, that's a lot. So it's not a lot different than the QHP, but we've already studied it. We think of 500% Medicare price cap, meaning anything under that stays under that. For VHI would be roughly 30 million. Again, 500%. To Chair Black's point, 500% is way too high. And, you know, I think Commissioner Sampson's idea of let's put a target out there and hold all of us accountable to it. Regulators, insurers, hospitals. And if we're not doing it, make us do it. And if we're doing better, give us a way to go. And I just, the studies, and the QHP number, you know, our estimate on the QHP, if there was a 500% cap of Medicare for all Vermonters, our portion of it, now we're less than 50% of the QHP, is about $32 million. So that gets you up pretty closer to 80. And also spreads the benefits across the other 90% of our residents.
I'm wondering if spreading the benefits in that way reduces the premiums for everybody simultaneously. And because right now this may be a lot of, well, I'm just wondering about that.
Yeah, so we estimated savings from, I'll give you Act 55 as a real tangible example. We estimated those savings at $87 million, and then we reported a 4% downward pressure on premiums. So outside of the QHP is a small number of people. So when you take our number for the QHP at 250%, if everything under that was capped, is $74 million. So that's just us, and we're less than half of the QHP. So we would agree. We think we're somewhere in the 13 to 15% premium reduction for the QHP if we had broader savings or similar savings over a broader group of folks over a number of years, because we won't get to 500% in 1 year. It might take 3 years, 4 years to get there. And then when we get there, we go to 300 or 200.
So the 14% is if it's all dedicated to the QH.
Correct.
And what if we didn't do that? What if we did, as you've talked about, dispersing it every Vermonter? Then what is the reduction?
Yeah, so it's another interesting point. And again, I'll go back to what Commissioner Sampson talked about, the combination of, and before I answer your question, I am going to say some things to be mindful of. We've got several new hospital CEOs. We've got a relatively new, maybe second year chair of the care board, a new commissioner of DFR, new CEO at Blue Cross Vermont. And things are working. We're listening and we're doing the things that we're being asked to do, and it's working. So that total dollar amount might be a higher premium reduction because the premiums aren't going to go up as much anyway. We'll file our rates May 11th, so you'll probably see sometime that week that get out to the media about what we anticipate rates for 2027 will go up to. I think we're pretty comfortable saying we'd love to see a 3 to 4% downward pressure that goes across all of Vermont if we stack that year over year for the next 2 to 3 years, and design a better QHP, the tactics and mechanics. We think we can accomplish a lot more.
I see, Leslie. I'd like to say this again, and I said this when you testified earlier.
Yeah.
I find it very difficult. You sit here and tell us how hard you're working this year. We have these rates as high as they are because Blue Cross Blue Shield of Vermont allowed it over year after year after year of cumulative non-negotiation, whatever it was. That's why we're in the position that we're in right now. So
yeah, I hear you. I would say that there's other folks in the room and other entities in the room that hold responsibility. So I think it's important that we acknowledge all of the responsible parties and say it's not just one.
I will agree. I will agree to that. What I did want to say, however, and I know Leslie has a question, I'm afraid that I've lost a little bit of the thread of your testimony. I'm not sure. None of your written material has the dollar figures that you've been putting out. So if you could get that for us.
Sure.
I'm not sure where you want us to go. In the end, you also said that you'd like the bill as written. and that it was all agreements. And you think, which I would say, I don't think that the Committee on Healthcare weighed in on their opinion on the agreement, so I'm not sure agreements between whom are we talking about here? But if you could get us clear written testimony, each section, what you would like to see, what you think is the best way to go, what you would, there was a study in here that you were talking about, you thought it would be great to have this study. And I'm thinking in my head, you're an insurance company, why aren't you studying this all the time anyways?
Right. It's all
So
done.
that would be great. It seems like that's your responsibility, not the state's, to tell you to do that. Leslie,
Thank you.
Go ahead.
I'm a little overwhelmed to be honest, by the language of the experts coming at me and following it along. So I need help with that. And I don't know what that looks like. But I'm just reading, I've heard a couple of times that Act 55 is solving some of these problems already, and we don't need to do more work, but I'm just reading Act 55 and I'm not seeing it. So either I'm missing something major, because I was just looking at the 340B
I think
program.
that was the ASP price cap.
That's what they're talking about.
Mhm. Mhm.
Okay. But that was one small section, so that covers that.
Okay.
So I think I need to understand how it unfolds, I guess, in the,
Yeah, I would.
in this bill.
So for me, and I'll clarify, I think Act 55 was the test run that we're saying maybe we need another one of in the QHP. I think we've heard testimony from hospitals pretty clearly saying that Act 55 is working. We certainly know that it's been working on our end. That was our first attempt
Okay,
at
so the
reference-based
200 bringing all
pricing.
that, yeah,
Yeah,
okay,
that-
now I get, okay.
So
Thank you.
when I say, and it is a little confusing because I can't sit here.
I don't live this, so
Yeah.
that's why I'm trying.
I can't sit here and say that we don't support a $74 million reduction in prices at hospitals. What I can say is we can do it. And I also have to sit here and say that our mission and our statutory obligation is to all Vermonters. So we would prefer a solution that benefits all Vermonters and has downward pressure on prices at hospitals for all Vermonters. And we think that there's a number out there, maybe it's 500%, that regulators, hospitals in our negotiations, our insurers in our negotiations with hospitals in their price reductions can use as a target to begin to achieve savings for all Vermonters. So I will say clearly, if we pass this bill as it is, we can't argue with that. We're an insurer. That's $74 million that we can put into premium savings for 30,000 members that we serve, and maybe more if they go into the QHP. All I can say is that we don't think that we need a test because we already did the test, and we think that it's time that all Vermonters get the benefits of reference-based pricing.
Okay, so if I could, we have 3 new committee members who didn't participate in Act 55, and maybe there would be some benefit just to help understand how it expands. So I'm understanding now. I get it, but it's not easy. And we've been hearing a lot of numbers been throwing,
numbers
a
today.
lot of numbers
It's
throwing
really
at
hot.
us, and
It's really hot.
it feels like, whoa. So some kind of refresher and how it applies
And
and
how we can repeat it.
We are,
how we want it.
we're gonna take this bill sort of, I don't wanna say section by section, but pieces of sections, or multiple sections. And when we do like the reference-based pricing part, we'll go over all of that.
Yeah, that would really.
Can I ask you one last question, and then we're gonna move on to Devin? We had Stephen Loeffler in here a couple weeks ago, and he indicated that how much they are down based upon what their anticipated budget was. To include, which I found shocking, is that utilization was not. So Green Mountain Care Board has no ability to make adjustments to Blue Cross Blue Shield's rates
Mhm.
that payers pay, or that people pay, subscribers. I'm imagining if UVM is not doing really well and that was unanticipated, can I make an assumption that Blue Cross is doing really well and that also was not unanticipated or not anticipated?
Yeah, I think it's a good question. I don't know enough about UVM's position. We could certainly get the committee some reports on their utilization. We do have at least our share of the numbers and the claims. And I know that Dr. Leffler and our CEO, Beth Roberts, talk frequently, especially about the things that you just mentioned, and the frequency of that communication escalated after the testimony. And I think, what are we, 4 full months almost through the year? Probably too soon to tell where we'll end up. We could draw some assumptions. I mean, yeah, UVM Health or UVM Medical Center by far is our largest hospital.
I'm just wondering, 4 months in, if you're noticing that, hey, we have a lot more money sitting in the checking account than we anticipated?
Yeah, I hope so. Mostly.
No. Have you looked at your balance is what I'm asking.
Yeah, I could certainly have some numbers for you in a follow-up. I do have a written testimony that will give you more specifics of where I think we can go. And I would say too, that's what we need. And we did a solvency brief with this committee. We have a long way to go before DFR says Blue Cross is in a great place. We don't need to worry about them anymore. And we're also worried about hospitals. So that conversation between CEOs is about how to solve a problem.
Thank you.
You're welcome. Thanks very much.
All right, Kevin. It really is today a hot
Sorry,
seat.
I didn't make that.
Good afternoon.
Good afternoon.
Devin Green, Vermont Association of Hospitals and Health Systems. Thank you for having me in on this bill today, and appreciate giving a sort of high-level overview of our positions before you dive further into the bill. Section 1, reference-based pricing reporting. The Green Mountain Care Board was hoping that the payers and the providers could set their prices as a percentage of Medicare. And that's what this is proposing that we do. Both to just get used to seeing our prices as a percentage of Medicare, and also for transparency purposes for when we list it on our websites. I am all for the transparency piece and listing it on our websites. It is actually difficult for us to convert our prices into Medicare on our own. We would prefer that the Green Mountain Care Board do this work, or we could come up with a list of prices. But this is all a bit confusing because the definition in this section is the definition of Medicare in this section is what hospitals receive. And if we go forward with hospitals having to do the calculation, we would like it to stay as what hospitals receive in Medicare, because we do know those numbers and we can do a percentage off of that. If we get into the other definition of Medicare that's in this bill, the base rate with everything stripped out and just the base rate, that is a lot more difficult for our hospitals to compute, and we would want the Green Mountain Care Board to do that.
It's on your hospital transparency tools. What is that? Is that the base rate or is that the rate with all the other stuff in
The
it?
Medicare piece, price piece.
Medicare. If I go on, I can pull up a spreadsheet and say, this is the Medicare allowed amount. Does that include all the other payments on top of it, or?
That does
Is that
include all
just
the,
the Medicare base rate?
my understanding is that includes all the payments on top of it.
Okay.
So we could do it off of that. We could look at our sheet and do it as a percentage off of that. If we're stripping everything out and just doing the base rate with nothing on top of it, and it's something different than what we receive as the hospital, then we would like the Green Mountain Care Board to do it.
Do hospitals really not know what the base rate is for every service that they have?
Well, for critical access hospitals, so yes, we know it for some places, right? We know it for inpatient. That's fairly easy to calculate, but for things like critical access hospitals, to convert to PPS rate and then to some base rate is really difficult. And we do not have the resources to do that work.
Thanks.
Section 2, the QHP at 250% of Medicare plan, I'm gonna say this again, we have an affordability action plan. We worked with consultants over the summer and fall. We reduced operational expenses by 230 million for FY 2026. That was a heavy lift. Continues to be a heavy lift. We pledged to further reduce operational expenses by $50 million a year for FY 2027 and FY 2028. That will be a total of $330 million over 3 years. That is what we're doing. And that's what we think we can do pretty safely. We also think that we can participate in hospital transformation to save $40 million per year for 2 years. The QHP is at 250% of Medicare is an issue for us because the latest estimates that we have seen are coming in at $130 million to $150 million per year. And in our minds, this may even be conservative because we do think that while we are working well with Blue Cross Blue Shield, we work well with MVP, we think that other larger insurers are going to come to us and say that 250% that those plans are getting, that's what we want, and that's what we're going to do. And so we think it'll be further losses for hospitals, and we have a lot of concerns about that.
I mean, what?
Further losses for hospitals.
You can say no.
Then they can send people out of state. We've seen MA plans has say that we are not going to send anyone to a Vermont nursing home. They have to go out of state.
Maybe they should. Anyways, I was like,
So I see your bottom line, QHP is at 250%. Do you have a percent you can?
If it is within the $50 million for this next year, yeah, we can do that percentage.
So you're saying,
So I don't know how that converts, but I'm saying if we are saving the QHPs, if we are saving the QHPs $50 million, we should be able to do that.
so you're gonna be able to give a percentage at some point, or is that what you're thinking?
Yes, we can try to get a percentage for you on that.
Thank you.
Daisy, and you might have said it and I missed it, but how did you come up with this 50 million number?
We worked with Kaufman Hall consulting firm over the summer and fall to look at what operational expenses we could further reduce after we did the work for FY 2026.
Can you say more about that, what those were?
I'm happy to come in and go through the findings there. The way it worked is we received statewide numbers and each hospital received their own report in terms of how they could save money. We did not receive those reports because of antitrust concerns, but each hospital got their own suggestions.
Yeah, because I'm just looking at that and I'm thinking, amongst the network or the system, there must be some variance, obviously, in who can shred what.
Yes.
So I would just hope for more flexibility amongst all of them.
Yes, and I think that's what would be helpful at this time too, instead of a straight, the ability to be more flexible would be very helpful because it is not equally apportioned.
I'm confused. I know the Kaufman Hall thing, you guys had like, oh, we're gonna do 50 million a year for the next 2 years. What's the hospital transformation 40 million? Is that in addition? Is that part of the 50? Is
That is in addition, so the $50 million a year for 2
Yearly?
years.
Or is it cumulative? Are you gonna keep transforming or are you just gonna like get 50 million in transformation and stuff?
I think we're always gonna have to transform. But with the work that we did, the 50 million was reducing operational expenses. And then the 40 million was service lines. So service
That'd be one
lines,
time, wouldn't it? I mean, if you eliminate service line, then you're done.
I think it was $40 million or no, maybe. I think it was actually $20 million a year for 2 years, for a total of $40 million over 2 years. That is where that ended up.
But then if you eliminate a service line, then
That savings is in there.
I mean,
that's
that
baked in.
wouldn't be ongoing. It would be just the one time.
No, I mean, it would be baked in. You wouldn't decrease every year, but you would
Yeah.
set a new baseline.
Yeah.
Yeah. So we do not support the QHP at 250% of Medicare.
How do you feel about the state employees and the EI in there?
Because they are the same amount, we do not support that either.
It's not in there now, but how about capping radiology at 500%?
Well, I think it depends, like what we have heard is capping radiology at 500% and labs at 300% is $100 million savings for Blue Cross Blue Shield, which is just Blue Cross Blue Shield. Not, if we're capping it, I'm assuming that's going to all other payers, which is significantly more than $100 million, and we would not be able to do that.
Do we realize what it says when it says we cannot cap something 500% of what it should cost?
I agree that 500% is too high. I completely agree with that. And we would like to do something about the high prices, and we would like to target them first. And I think 500% is a good starting point, and definitely not the end point, right? We have a lot of work ahead of us. So I think the other piece in here, so the way the QHP plan works is, or for our hospital budgets at least, the way it works is 250% of Medicare. If you are still higher than your budget, then you need to target those prices that are over 500%. We do not agree with the QHP piece, but we do agree with the targeting prices over 500%. That doesn't necessarily mean bringing everything down to below 500%, but I think that that is the place to start. Any questions on the
Leslie, we're done.
Reference-based
We're done with
pricing piece.
reference-based pricing. Do you wanna?
Got the memo.
The hospital outsourcing piece, I do support the current language in there and doing a stakeholder process to look at outsourcing. There's been this, I'm afraid, gets into the what is a hospital question that we talk about, but there's been long arrangements of medical groups contracting with hospitals to provide the service in the hospitals. You just heard the Rutland Regional Medical Center pediatricians saying that they were with the FQHC and they had contracted with the hospital. You may have seen that Northwestern Medical Center has contracted with Maitri to maintain their OB services. We hear the Green Mountain Care Board's concerns and the dynamic that may play out with outsourcing, but we have always been very public about how outsourcing works, as you can see from these headlines, and we are happy to do reporting and discuss with the Green Mountain Care Board how it might work. We don't want to jeopardize any current or future relationships by putting a new regulatory scheme in place without diving into the matter. So we support the sort of stakeholder process that's in the bill right now.
You mentioned Maitri, and we just heard from the pediatricians from FQHC in Rutland. I remember I asked the pediatricians, who bills? Right. And I think the question
The
is,
hospital.
who bills? That's the outsourcing piece. And I think the original version of this required that the hospital, that it be in the hospital's budget, and it would be subject to orders of the hospital.
Mhm.
So that wouldn't have taken away the two examples that you just cited.
Correct. And I don't know if it takes away, so this came up with Springfield Hospital and Blue Water and their Blue Water contract going away. This is also happening at Brattleboro Memorial Hospital. Their provider died suddenly and they needed to contract with someone for those services. Cheshire Hospital was contracting with their ED and Cheshire left and they needed to get providers in right away. I would like to ensure that I am not necessarily against regulating this, but before it's regulated, I want to see what the impacts might be so that we don't create an access problem to care, especially in emergency departments.
I think I'm starting to understand a little more. This section's really important and I'm struggling to understand the rationale because if you've always been transparent about these relationships, how do we still not understand the impact?
I think we do. And I mean, I don't know where the disconnect is on the impact necessarily either. And that's why I think it's worth having a study about it as opposed to immediately regulating it.
Okay, so that's your recommendation as a study.
Yes. And recommendations for what the Green Mountain Care Board wants to do.
It's like,
But isn't it a report now? So maybe I'm missing.
It is a report now. In the original language, it was
Okay, but
regulation.
we're not looking at the original, are we? I'm looking at this.
no, I think that the original language was the intent was that it became known this year that there was outsourcing that had been completely unaware. And so there have been moves to allow the Green Mountain Care Board to capture that within the regulatory process.
So, but the outsourcing isn't part of the hospital budget. Wouldn't it have to be? How could they be paying?
I think it is typically,
How could they be paying Blue Water or whomever this is? Blue Water's gone, I get it, but whatever. Or maybe they're not. Oh, that's a different headline. Yeah, you're confusing me.
sorry.
Sorry, okay, whatever. So what I'm not understanding is if Springfield Hospital is contracting with an organization to staff their emergency room, why is that not in their budget submission?
I don't know. I think hospitals are happy to report. I think that's typically in the budget submission. I don't think hospitals have been trying to be, again,
I don't
they're
see
not
why
trying to
they're
make it a secret that
Why aren't they
these,
required to report it? I mean, not required, but why isn't it just part of normal business that they report this expense?
I think maybe it was not captured in the budget guidance. It's certainly captured in the budget guidance this year. And there may have been misinterpretation of it.
And I will say the other thing is that if it's not the hospital who's doing the billing for that provider service, There is no claims tax on that.
Well, there may not be a claims tax, but still, if you're looking at your expenses, you are buying it. I mean, Brattleboro bought an ER service from Cheshire.
That
That
is
had to
reported.
live somewhere.
Yeah, that was reported.
We'll take testimony on it.
Excellent.
All right. Let's go. We've got two more sections.
Yes.
Okay.
Health system performance tool, I'll just go by this really quickly. Baz has been working on this. We are running it by our members right now. We're hoping to have it out fairly soon and available to the public. We'll have a tool measuring financial components, quality, and access.
How often do the hospitals report their quarterly financials to the Green Mountain Care Board?
I believe quarterly.
Quarterly? Has the first quarter's been received yet? If they have, it would be great if we could get the first quarter.
Section 11, the critical access hospital Medicare cost sharing issue. I will say on this issue, we agree that the Medicare policy of basing out-of-pocket costs on hospital charges instead of reimbursements is a bad policy. It is bad for hospitals. It is bad for Vermont patients. We do not agree with the policy, and we want to work on the policy. We are concerned about finding a policy, a hospital, like, we are concerned about finding a fix for a federal policy in our hospital budgets. And that this could be really destabilizing for our critical access hospitals. And I just want to go through this a little bit. So in the Green Mountain Care Board hospital budget guidance, they said that they would take steps to address this Medicare issue. And some of the things they would consider would be reducing charges, limiting patient cost sharing, requiring public notice and full transparency, or potentially other ways of addressing this issue. I want to point out that this federal policy is a problem in every state. So here's the 20% line. Vermont is here at 48%. This is NASHP data. Everyone is over this 20% line. It's a problem in every state, which is why we think it should get a federal solution.
This is 20% of what the customers pay, this is the hospital.
I believe it's 20% of the like reimbursement to the hospital, that line.
Okay. I just read all the letters that critical access hospitals sent to the Green Mountain Care Board. And basically they all said, we can't really calculate this. So how are we getting a calculation?
This is the calculation from NASHP. I'll be honest, I do not know how they calculated it.
So they use the Medicare cost reports at hospitals.
Yes. Yeah.
But also, all those other states do not have healthcare costs like we do, right?
But that is commercial insurance, right? Like, this is, and I question about the other states. We do have high prices. I agree with that. We're working on bringing them down. A lot of progress has been made. But price is different from charge, and this is based on charge. So it is possible that those other states also have a high charge master.
Do all these other states have 50% of their hospitals as critical access hospitals?
I would have to take a look at which states do. I believe there are some rural areas that have significant number of critical access hospitals.
But even Wyoming is way lower. I was looking at Wyoming, and even Wyoming is way less than us.
Critical access.
So I want to take a look at the first suggestion from the Green Mountain Care Board in our hospital budget guidance, which is to reduce charges to Medicare. And I want to point out that I think you all know this very well. Critical access hospitals get paid differently. They are supposed to get paid at cost. They're actually supposed to get paid 101% of their costs. Due to federal sequestration and budget stuff, they actually get 99% of actual costs. If the Green Mountain Care Board has hospitals lower their charges to the Medicare amounts, that means their charges will be at 99% of costs. Commercial contracts are often a percentage of the charge. And so that means many commercial payers would come in and pay a percentage of that 99% of costs. So what that looks like. What that looks like is, and this is just for illustrative, this is not, you see the sort of cost shift that we all talk about where commercial insurance is subsidizing Medicare and Medicaid. If you bring down commercial insurance, or if you bring down our charges to the Medicare amount, commercial insurance will be a fraction of that. That will likely end up in hospital closures. We will not have a way to make money. It's possible Blue Cross Blue Shield or MVP would not do that, not be a percentage of our costs, but it wouldn't act, or our charges, but it wouldn't actually make much sense for them because insurers send out your explanation of benefits that says, here's what you were charged. Here's your discount. Here's what you saved. It would look pretty funny for an insurer to say, here's what you were charged. And you actually had to pay more than what you were charged. It wouldn't work out. The math wouldn't work out. And so this would have a devastating impact on the critical access hospitals.
Go ahead, Casey.
I don't know how to say this, but there isn't a single number on that chart.
It's for illustrative purposes.
So this is just art.
That's an important point. What's the axis? What's the y-axis?
There is nothing that says that you cannot negotiate with a commercial insurance that says you will pay us 250% of the charge, which is the Medicare allowed amount.
So insurers are going to say you actually paid more money than
So
if you would have paid in cash.
So you can't do it because it's uncomfortable for a patient to get an EOB.
No, we can't do it because we don't have the bargaining power against large health insurers. Our critical access hospitals do not have the bargaining power to do it.
Are you saying in Vermont or not?
Yes,
Yeah, that's what she said.
I would argue nationally too.
What about the patient here in this conversation? Where does the patient fall?
Yeah, I think the patients, I think what we can do in this piece with the patients is be very upfront, give them notifications, direct them to our financial assistance policies, direct them to the Medicare savings program.
Well, why wouldn't you direct them to PPS hospitals? Well, they'll get a better deal.
Well, we can tell them about the issue and we can direct them to our websites where they can see what the impact is on them.
Well, why not be upfront and say, this is what's gonna cost here and this is what's cost there, and so why go there where it's gonna be that much more expensive?
Well, because it may be different depending on the service.
I'm sure that's true, but I bet there's some patterns predictable. I would wonder.
Well, what you're talking about would be sort of like coordinated regional strategy to support all the hospitals, right?
And
Or
patients.
could be.
And patients.
Exactly.
I was gonna ask something and it left my head, which is probably for the best.
Good.
Yes, if you're directing all of your patients though to go to one hospital, aren't you risking all the others collapsing?
Yes.
None of this is good.
Oh, I know what I was gonna say. Thank you for saying that. Go ahead, Karen.
I mean, I was just wondering if, couldn't you just say, have it done in the hospital? Don't
So it's
go-
not an outpatient procedure.
Yeah. In all circumstances, just come to our hospital. It's a call to people out of the hospital.
Right, that's the part of the problem. Come to our inpatient.
And
Of the critical access hospitals,
Mhm.
we're only talking about outpatient charges here. Not inpatient. Is there a sense of where the prices are, where the charge master is currently in relation to its highest reimbursed contract? Has that calculation been made? Has anyone gone and said, here, for every single outpatient charge, and remember, it's a little easier for outpatient rather than inpatient. Because of bundling and stuff like that, but has anyone gone and said, where is our price on our charge master in relation to who we get the absolute most from? Or is it just some random number that just every single year just keeps going up and up and up without any real tie to anything?
Hospitals are encouraged to look at their charge masters. I don't know if that calculation has been made. I can check.
Okay. Yeah.
The other option the Green Mountain Care Board has put out there in our hospital budgets is limiting cost sharing, which we do have concerns about. We know that individual hospitals have, it's been a violation of federal law to limit their cost sharing. It's considered like an inducement to get patients there. And it is not allowed. So we know that individual hospitals cannot do this. We think that there are a number of other issues around the calculation of the actual costs if you limit your cost sharing as well. And so we are looking into what the federal government would allow us to do. This was very much a choice by the federal government back in the late 90s to save money. They wanted to shift this out to people and to plans to save money. So we do want to tread cautiously around the legality of this all, and we're in contact with CMS on it. Unfortunately, CMS does not move with the lightning speed that we would like them to.
Can we talk about dual eligibles?
Sure.
So currently Medicaid, who's secondary to Medicare, would come in and they would pay the cost share that Medicare says is the cost share. That's in the state of Vermont.
Right.
That is the way it works.
Yeah.
Other states set that Medicaid pays only up to what the Medicaid allowed amount is. Would Voz be in favor of advocating that that be implemented? That doesn't get in the way of a violation of federal law. And that's state dollars.
That is state dollars. It wouldn't help individuals directly in the way I think
Would help
we're hoping to.
taxpayers.
I would be happy to go back and look into that. It would be an impact to the critical access hospitals, which are struggling. As I mentioned, we are happy to work on transparency. We are happy to work on federal solution. We have been in touch with our delegation multiple times on this issue. We have talked to our colleagues at the American Hospital Association on this issue. We're hoping that they will elevate it. We would really love to see a federal solution that fixes this problem nationally, as opposed to a solution in our hospital budget process, which is why we pledge to continue to work on this, do the stakeholder group with the Green Mountain Care Board, look at solutions to this problem. We just don't want it unilaterally done in our hospital budgets, which could be very damaging to our critical access hospitals.
I make the assumption that it was the Vermont Association of Hospital and Health Systems that had put into this bill that the Green Mountain Care Board shall not address or even attempt to address this issue?
Yes.
Okay. Leslie?
What have you heard back from the feds, from our federal delegation? Are they engaged with it or not?
I think they understand the problem and the issue, and they are up against the challenge of our federal government right now.
Which makes sense, but does that mean that we have to give up on people in Vermont who are now sort of operating under this dynamic because we can't get a federal fix, which is not going to happen anytime soon? I think we could agree. You're willing to go that way, I guess, is what I'm asking.
I'm willing to, through the stakeholder group, if we are able to come up with something that is not in our FY 2027 budgets and it's not reducing our charges to Medicare and telling us that we might have to telling us about the cost sharing, if we can all agree on a solution statewide that would work for hospitals and for Vermonters, we would be happy to do that. My sense is that the best solution would be from a federal fix.
I'm sorry, I'm very frustrated with this issue. And we have taken testimony on this issue. I mean, I'm sitting here looking at public notice and transparency. And I will just say, this has been happening for years and years and years. And critical access hospitals never said a word about it. This came about from a public. And so I'm really frustrated that there seems to be this level of, let's not look at it, this is too hard, this is, the language in here, I don't think I've ever seen written into a bill that something should not even be looked at. Whatever you do, don't address it or even attempt to address it. It's just, to me, I am like, why?
We wouldn't do it if it wouldn't. We are very concerned it will close our critical access hospitals. That is why we went this extreme.
So our critical access hospitals are in trouble in spite of all this.
Right.
So there seems to be a real fundamental problem with the design of the system. And at the same time, particularly our rural elderly are being gouged. So I'm having a real hard time seeing that this did not fix the problem all these decades and you want to continue it. I'm having a hard time with that.
We committed to doing the work group with the Green Mountain Care Board. That shows our commitment to working on this problem. We do not want our critical access hospitals to go under.
But maybe if the business model is not okay and some should. I'm just throwing that out there. I don't know that answer. I'm just saying.
No.
The business model is not working so far.
If the business model is to please rural Vermonters, is that a business model we want to sustain?
It's a Medicare model that is impacting everyone nationwide.
But now we know about it in Vermont. Does that mean we say, okay?
No, but it means that we go to our delegation, you go to your counterparts in other states to put pressure on their delegation, and we look for a federal fix.
Or we could at least start with looking at our own charges and saying, let's just look. I mean, that's the thing I don't get. It's like, nobody even wants to look.
It's not just looking, it's putting our charges to Medicare rate.
That is not what I'm saying. I understand that it is probably a federal fix. I understand that this is the way the system has been designed. I am not saying that it can be fixed, but all I keep hearing is it's too hard to even look. I mean, yeah, your charges. You've been raising your charges 3%, 4%, 5% every single year, whatever the board says. And has anyone ever looked to see whether or not we get anywhere remotely close to this from a commercial payer? I mean, maybe we're outsized from even a commercial payer standpoint. But lowering our rates to what the highest commercial would pay, it wouldn't affect anybody at all. It wouldn't affect anything. But I get frustrated with don't look or don't even attempt to look. I'm sorry, Devin. I'm really frustrated by this issue.
I understand.
And members in this entire body are being lobbied by their local hospitals to nothing to see here. Don't look. Don't worry. If you look at this, you will hurt your local hospital.
You might lose your hospital. That's the message. I'm stuck on the business model. I understand, but there's a problem that goes deeper in Vermont.
Okay, we're wrapping up. I probably should have taken a break. Thank you, Devin.
Thank you, Devin.
Thank you.
Okay, we're all done for the day. I'll see you back here